Hi everyone, my name is Tom and I am the events coordinator with Evidence Synthesis Ireland. So we're delighted to welcome you to this exciting webinar on embedding patient and public involvement in medical education evidence synthesis. So just a brief introduction for those of you who mightn't know much about us, ESI, which includes Cochrane Ireland. It's an all-Ireland initiative funded by the Health Research Board and the Research and Development Division of the Public Health Agency in Northern Ireland. Our aim is to build evidence synthesis knowledge, awareness and capacity on the island of Ireland. We have a number of key activities for achieving that aim, and one of them is a monthly webinar on an evidence synthesis topic. Our presenters today are Professor Sophie Park, Dr. Sadie Laws-Wickwire and Julia Hammer-Hunt. Sophie is a professor of primary care and medical education. She is a GP and director of medical education at UCL Medical School. Her research explores patient involvement in general practice medical education and how the organization of primary care impacts on patient experience. Dr. Sadie Laws-Wickwire is a health psychologist, associate fellow of the British Psychological Society, and a fellow of the Higher Education Academy. Sadie is an academic based at UCL in the Department of Primary Care and Population Health. Julia Hammer-Hunt is a PPI evidence synthesis contributor from the NIHR School of Primary Care Research Evidence Synthesis Working Group. She is a member of a study steering committee for an NIHR, HS and DOR evidence synthesis and stakeholder consultation project at the University of Manchester. She is also the patient co-chair of the OHBRC Patient and Research Group and honorary member of the Department of Psychiatry at the University of Oxford. The webinar itself is pre-recorded, but we have Sophie and Julia on the line to say hello before we begin and to answer questions and have discussion at the end. Sadie is unable to join as she's currently on maternity leave. But before I hand over to Sophie and Julia to say hello, I'll just provide a bit of background on the webinar topic, which is public and patient and public involvement in evidence synthesis. Our presenters will share two examples of medical education reviews involving academic and PPI collaborators. The first explores how patients and public are involved in remote teaching clinical interactions. We include reflections of a PPI contributor about being involved in the review process. The second pioneered a new approach to analysis, embedding patient and student user perspectives into the analysis of an evidence synthesis. The final section of the webinar will be a space for discussion to share challenges and opportunities to embedding patients and public in the design, delivery, and research of medical education. We will have time for questions at the end, and we also hope for a lively discussion. So we do encourage you to type your questions in the Q&A section at the bottom as we go along. And you should hopefully be able to upvote these questions as well. We will be making a recording of the presentation available on our website, and we do encourage for you to sign up to our newsletter too. So I'll hand over now briefly to Sophie and Julia to say hi, and then we will begin the webinar. So Sophie.
Hello everyone. So thanks ever so much for having us today. It's delightful to be with you all, and really looking forward to some discussion and debate later. Julia.
Good morning, hello everyone. I'm the lay contributor to this session, and I have had possibly the least input, but I'm not going to say an unmeaningful input to the process. So looking forward to the webinar.
Thank you both. I'll share the webinar now.
Hello. Thank you so much for inviting us to meet with you today. My name is Sophie. I am a GP and Professor of Medical Education and Primary Care at UCL. In my research, I often use evidence synthesis approaches, and increasingly I've been reflecting on the role of experiential knowledge within this process, and in particular the involvement of service users such as patients or students. So I hope through sharing this presentation with you today that I might invite you to consider the role of experiential knowledge and expert by experience involvement in your own work or contributions. So we're going to share a couple of recent studies that we've done together, aiming to develop fine ways of patient and public contributor involvement into our evidence syntheses. Our work focuses on medical education, but encompasses primary healthcare design and sustainable workforce delivery. I will share 3 recent approaches to PPI collaboration, and then Sadie will describe a recent rapid review that we've done about PPI in technology-based medical education. Afterwards, we look forward to questions and discussion, and I am delighted that Julia is joining us today. Thank you. In 2015, we conducted a systematic review of undergraduate medical education in the general practice setting. And one element of this was an in-depth meta-ethnography using qualitative papers. This focused on student and patient perceptions of the socio-cultural spaces for learning and interpersonal interactions in the teaching consultation. While we had both user, student and patient involvement within our review team, we were keen to extend the process and take the findings of this initial meta-ethnography to patient and student participants, explore their responses and embed these into further stages of the synthesis. We called this study PATMED. Meta-ethnography is traditionally a 7-stage process of interpretation. Having completed the initial expression of synthesis through publication of the review, we took the findings into patient interviews and student focus groups to explore their responses. We then embedded these audience responses into an extended meta-ethnography, synthesizing these with the existing findings. This enabled us to refine and develop our findings and then re-express them. We've represented this process here in a spiral of knowledge production and interpretation. So at the top, we have the initial patient and student experiences of teaching encounters. Some of these were then reported and interpreted within the included empirical research papers that we looked at in our review. We then conducted the synthesis, and a further layer of interpretation happened during our meta-ethnography process and production of a set of models. So this extended meta-ethnography, we then took these models to patient and student participants to develop them further through the extended synthesis and re-expression. So as I mentioned, there were 2 main meta-ethnography models, and I'll share briefly how these evolved through PATMED. So first, looking at the tensions between general practice and hospital settings as a socio-cultural space for learning, you can see in red how the participant responses help to provide more in-depth understanding of the tensions. Looking now at the interpersonal interactions, in our initial model, we had identified the GP tutor as a broker of teaching interactions. PATMED extended this, highlighting the potential for both student and patients to broker as well. Participants highlighted the importance of the language of consent and its importance framing the student position in the community of practice. Next, the importance of the space in which the consent was broached. So patient participants reported much preferring a non-doctor space, so for example, a corridor or the waiting room. The next area highlighted was the dynamic nature of negotiation of legitimacy within the community of practice. So for example, there was a temporal shift for students with increasing seniority. The extended meta-ethnography also highlighted the fluidity to the transactional nature of establishing their currency in the community of practice. So for patients, for example, in relation to their knowledge of a condition as expert patient, and students' currency, for example, devalued when a patient had an intimate problem or there was a gender mismatch, or maybe the GP tutor on that day didn't know them well. So I'm now going to introduce a second study, this time an evidence synthesis using a realist methodology. So we were examining reported ways of integrating PPI and stakeholder involvement into realist healthcare reviews. So having done the meta-ethnography study, we began to think much more broadly about PPI involvement in reviews. PPI is an expected component of healthcare-related studies, and organisations such as Involve, for example, support this. Researchers are increasingly being held to account for facilitating such involvement and reporting accurately the roles and contributions in papers written. PPI has become commonplace in clinical empirical research, is beginning to be introduced into medical education empirical research, but is as yet less commonplace in evidence syntheses. So in this second example, we focused on realist reviews. So realist reviews explore interventions or phenomena and seek to produce causal explanations for what works for whom and in what circumstances. Realist reviews have sought to include a range of forms of knowledge, such as great literature, unpublished literature, in addition to quantitative and qualitative research. So there are a number of potential stages at which PPI, stakeholder and research team experiential knowledge might be valuable within the realist review. So for example, during production of initial program theory in the protocol, or during stages of analysis to ensure that findings are relevant to user perspectives, practice and policy. So I invite you now to reflect on the purpose of experiential knowledge in evidence syntheses and how this shapes interpretations made during the synthesis process. So what might the purpose of patient and public perspectives be, stakeholders, experts, or indeed researchers' own experiential knowledge? There are, of course, a range of potential passive to active possibilities for involvement and co-production. So it's important to ask who is being involved and what is the terminology being used to refer to them. So each review has different needs for PPI, and the different purpose of PPI may differ across different reviews, in addition to variable terminology. Next, why are they being involved? So what are the roles defined, the boundaries and the expectations? Then how? So how is this involvement being operationalized, and what structures are in place, for example, to manage power dynamics, relationships, processes that limit or enable involvement? And how is this reported to have shaped or impacted upon the review process and outcomes? So in our review, we identified 72 relevant papers at full text, which were realist healthcare papers, which included reference to some form of PPI or stakeholder involvement. And we used framework analysis to synthesize the findings. So you can see on this map, there were 16 papers from North America, 5 in Australia, and 51, this was pre-Brexit, in Europe, of which 37 were in the UK. So there were 3 main themes identified: nomenclature, nature of involvement, and reporting impact. So first, nomenclature. So papers indicate that contributor involvement in realist reviews refer to stakeholders and experts of advisory groups. Patients and public are often subsumed into these groups, and in so doing, the nature of their involvement and reporting of the impact of their involvement is often unclear. 4 papers made direct reference to patient involvement but did not label it as such, referring, for example, to stakeholder group interviews, advisory group members, or patient stakeholder workshops. Of the 25 papers referring to experts, 7 studies refer specifically to service users who were positioned as members of the public. 1 paper referred to peer researchers for service users within their advisory group. So next, the nature of involvement. This varied. So stakeholders, for example, policymakers and service users, tended to be involved during initial stages of realist reviews, for example, to inform the initial program theory development. Studies drawing on expert or advisory panel groups, such as academics and clinicians, appear to be more likely to describe involvement in research question production, sharing relevant literature, or elements of data extraction and analysis. Papers involving patients described experiential knowledge input into program theory development or advice throughout the project. Where provided, reporting included description about how a particular group or meeting might have shaped emergent findings, refined the program theory, or enhanced conceptual clarity of the review's mechanisms. Reports of impact were often contingent on the timeline of the project and the publication often being quite early in relation to potential impact. And we highlighted some important considerations, including word count, research funding, timelines, research agendas, and researcher experience in relation to this reporting of impact. So we've produced some prompts for both researchers and PPI, which we hope will be useful in both healthcare and medical education realist research. First here for researchers, and second for patients and public contributors. So in summary, it's really important to consider the terminology, the nature of involvement and the reported impact. These are often underreported or lack detail and distinctions between roles and identities. And there are definitely opportunities to develop further in collaboration with our contributors. And I would like to finish by sharing one example of recent work where we've begun to explore different medium for interacting with and including PPI, here using art to broaden our engagement with diverse groups and exploring research agendas for future evidence syntheses. So thank you, and I will now hand over to Sadie.
Hi, I'm Dr. Sadie Laws-Whitcomb. I'm a lecturer in medical education and a health psychologist in the Department of Primary Care and Population Health at UCL. I'm going to talk to you today about using technology in undergraduate medical teaching when patients and the public are involved in teaching sessions. So I'm going to share the results of a systematic review that I've been leading for the last 6 months. And the idea for this came from working with our primary care medical education expert by experience group during the COVID-19 pandemic, when we've been thinking about how to make sure that our activities can continue remotely and what we can do to support patients and carers to be involved at that level, at that strategic level of medical education, where they support us with reviewing our curricula. So we wanted to know more about what technology may be best, who's involved in medical education when technology is used, and how can we support people? Are there barriers that may need to be overcome during this new way of working when we're working remotely to deliver teaching sessions? First, I just want to acknowledge my co-authors on the review and the funders. So this was the systematic review was funded from a grant from the School of Primary Care Research and some funding from UCL. So in terms of patient and public involvement in medical education, this is something that's recommended by the General Medical Council and the World Health Organization, who recognise the importance of interactions between students and patients or carers in their medical teaching. So learning about real life settings, real life experiences of patients and carers can support students in their communication skills. We know that this way of working is a gateway to more person-centred care. And research tells us that students' professionalism and clinical and communication skills can be improved when patients and carers are involved in their teaching and learning. Research has also told us that patients and carers can benefit from being involved in medical students' education, and they report personal levels of satisfaction and reward. And this is something we know at UCL, where our very much involved patients and carers really enjoy being part of medical students' learning and teaching, because they get to share their voice and their experience about their conditions and their treatments, and making sure that their voice is central to medical students' learning is really important. So in recent years, there have been frameworks to describe what patient and public involvement really means in medical education. And Town and colleagues in recent years have brought these frameworks together into a taxonomy which describes a spectrum of involvement. So from the lowest levels of involvement, where patients and carers are actively involved in developing case studies for students, but where these case studies are presented to students later on. So there's no interaction between patients and carers. There's no contact between them and the students, but they are involved as part of these case studies. Similarly, patients and carers may be involved in students learning just through their clinical encounters with medical professionals where students are observing. Again, there may not be much interaction with students, or their interaction might be scripted. So when we look at these kind of higher levels of involvement, we're talking about patients and carers as partners with medical teaching teams to support students' learning. So they might be invited to teach students about their condition, or they might be more involved at a strategic level at the institution, where they're reviewing curricula, medical curricula, prioritising topics for medical students to learn about, or involved in assessing or evaluating students' learning. So how would patients and carers like to be involved in medical teaching? When we're thinking about their preferences for involvement, research tells us that they'd like clear information before any exchange with students. They'd like to know what they're being asked to do. They'd also like confidentiality, and they would like consent to be taken at each stage of the encounter. So, for example, patients might consent to students observing their normal clinical encounter with a healthcare professional, but they might not consent to students leading the physical examination. So consent needs to be sought at different points of the encounter. They'd also like to see medical teaching normalised. For example, at GP practices, patients have spoken about wanting to know that the practice is somewhere where students are going to be, and that they might be asked if they mind students being involved in their clinical care. Patients and carers don't want to be passive in encounters either. They talk about wanting to be involved in interacting with students and perhaps providing them feedback after the interaction to help students learn. So given how important this way of working is for medical students and for patients and carers, to make sure that students are gaining those real life experiences and developing in their patient-centered communication skills, we need to think about how to continue patient and public involvement activities when we're working remotely. So we know from some research and some anecdotal evidence about the sort of impact of the COVID-19 pandemic on patient and public involvement, where there's more emphasis now on IT skills, on finding results at speed, and having to deliver. We rapidly moved teaching online pretty much overnight, so there was a real kind of pressure on making sure that we delivered teaching at speed, and changing that format quickly. So, you know, were there opportunities for patients and carers to be involved in that process? Losing that face-to-face contact also means that there's less opportunities for teaching teams, for educators to have to be sort of perhaps debriefing patients and carers who are involved in teaching sessions, or seeking their feedback. So working online, using video conferencing software, there may be less opportunities for those sorts of interactions, for sort of coffee time and things like that. We also know that remote working involves needing a strong Wi-Fi connection, and does everyone have access to that? And what do people need to be able to access a strong Wi-Fi connection? There also seem to be sort of more difficulties building relationships. So perhaps in teaching sessions, there may be more difficulty between students and patients in terms of building rapport, given the sort of differences when we're using video conferencing software, where there may be disruptions, for example, over the internet connection, that may disrupt that flow of conversation. And we're also trying to make sure that teaching sessions aren't overwhelming and tiresome for students and patients alike. So sometimes sessions can be a bit shorter, which again kind of impacts on those opportunities for debrief or feedback or coffee time. So what should we be doing? What should we be thinking about? There are some sort of initial scoping reviews out there that have looked at how to support healthcare education and making sure that patients and carers are involved in rural health settings. So in these settings, telephone and internet technologies are used most commonly. But we don't really know much about the sort of levels of involvement and how we can support the different levels of involvement, perhaps higher levels, through these means. And does one size fit all? We need to think about who we may be excluding in this new way of working. And are there barriers that may need to be overcome to make sure that we're inclusive and ensure that patients and carers that are being involved represent the diversity of patients and carers that healthcare teams see. So it's important that students hear from a range of patients' experiences and hear from people with different backgrounds. So how can we support that and make sure that we're not excluding people who lack digital access? So the systematic review, in thinking about these things, our aims were to identify the uses of technology to support involvement of patients and carers in teaching medical students, and to identify the outcomes related to patient and public involvement when technology is used. What are the benefits to students, educators and patients alike? And to think about what populations are being involved. We sort of set out to find out if there were any barriers for particular patient groups or population groups to involvement when technology is used in students' learning. So as part of the research team, we had 2 public contributors who have lived experience of medical conditions and of being carers. And that was so valuable at the point of thinking about our inclusion and exclusion criteria and thinking about making sure that we're capturing the context of learning when real patients and carers are involved. So we decided to exclude any studies that reported the use of actors or other people who are otherwise not people with lived experience of the conditions they're portraying. So this was a rapid review, the benefit of which meant sort of producing context for the current situation, for the COVID situation. So for teaching teams trying to continue their patient and public involvement during COVID. So that did mean we omitted some processes without impacting on the quality of the systematic review. So we excluded non-English language articles and also excluded articles that we couldn't get hold of beyond our institutional access. So we registered the protocol on Prospero and searched for the studies last October. And we performed a quality assessment using the mixed methods appraisal tool and a narrative synthesis to bring together the findings from a real sort of heterogeneous literature. So after screening titles and abstracts as a team and full texts and identifying articles from some key articles that we'd found from hand searching references, we ended up with 20 studies in the review. So studies involved using a range of designs and the vast majority included were cross-sectional studies, so included surveys, qualitative interviews and some mixed methods studies using a combination of surveys and interviews. There were some randomized controlled trials, a small body of literature looking at sort of the longitudinal outcomes after using technology delivered using technology in medical education. So in terms of the types of technology that was being used in medical education, when patients and the public are involved, in the majority of cases, it's the use of video. So patients were interviewed, and this was pre-recorded before being shown to students in teaching sessions later. So really we're talking about no interaction between patients and students in those settings. And there was a small number of articles that reported the outcomes of using telehealth and remote consulting technology, where students were involved in delivering healthcare as part of their learning. And some of these studies were reporting from the context of COVID-19. So we captured some really up-to-date studies as well. There were some online interactive resources, again, where patients and carers were involved in kind of designing the content, but students didn't have any interaction with them in real time. So looking at the levels of patient and carer involvement, the studies that we included were mostly case studies or scenarios, so patients and carers were involved in designing or featuring in case studies and scenarios, whether online or over video, but where there was no interaction. And there was a handful of studies that reported where patients and carers were volunteers in their clinical encounters where students were involved. And that was that's level 2 in Town colleagues' taxonomy. So really we didn't capture any studies that were reporting higher levels of involvement beyond level 2. So in terms of the outcomes measured in these studies, we're looking at the vast majority reporting student level outcomes, so the benefits of involving patients and the public in technology delivered medical education were reported in terms of students. So acceptability or the educational value of the activity, their knowledge, the impact of these sessions on their knowledge, communication and clinical skills, and also some studies reported their general attitudes towards patients after the technology supported intervention. In terms of educators, there were minimal studies reporting educator outcomes, but generally this was their perceptions of acceptability and the educational value of the session. 2 studies reported the acceptability of the educational activity in terms of patients and the barriers reported by patients to participation, but these outcomes are reported from the perspective of students and educators. So actually no studies reported patients' perspective as directly captured from them. So in terms of the student perspective and student outcomes, when patients and the public are involved using technology, students found a range of different types of sessions to be acceptable and valuable to them in their learning, including the use of online digital stories of common paediatric problems. So this was going through an online session where patients were featured in videos and in stories and in photos. Also, this use of student-led telehealth clinics, so where students were involved in patients' care, direct care, using telehealth or remote consulting technology. Students found those types of sessions to be acceptable and valuable to their learning. Also, a range of studies that explored the use of video, where patients and carers shared their stories via the video, or videos of GP consultations with real patients. Students found these to be acceptable to and valuable to their learning. So in terms of students' general attitudes towards patients, sessions involving patients and the carers where technology was used were found to improve students' patient-centred attitudes, so videos and video simulations where real patients were involved. Studies also found improved clinical knowledge and improved knowledge of patient diversity when patients and carers were involved. Although there were some limited, a limited number of studies found no difference in students' knowledge. So there was a bit of mixed findings there. In terms of their clinical and communication skills, there were a range of benefits of patient and care involvement in technology-supported sessions for students. In terms of their understanding of patient-centered consultations, their skills in communicating with patients in a patient-centered way. One study also found improved OSCE scores, and another study where students were involved in the care of people calling a COVID-19 hotline improved students' skills in screening and triaging and assessing patients with COVID-19. But a couple of studies actually found that more traditional approaches were more beneficial for students. So, for example, in one study reviewing student-led remote consultations in primary care, actually some students reported preferring the face-to-face consultation format because the use of technology was a bit of a barrier to their building rapport with patients and carers online. And that actually students found the relationship much better when consultations were face-to-face. So in terms of the teaching team's perspectives of patient and public involvement, videos of GP consultations and students filming patients sharing their stories and using those as part of their learning were found to be acceptable and valuable as part of students' learning. But the physical distance when students led remote consultations between the student and their supervisor was a bit of a barrier, reported by some supervisors in this qualitative study. So the physical distance meant that there were less opportunities for providing students with feedback, and GP tutors reported that it was a bit more difficult to build relationships with students online. So in terms of the patient perspectives, when students and educators were reporting these, students felt that the consultations that they led with patients were acceptable to patients. But in one study where students were involved in delivering healthcare using telehealth technologies, actually almost 50% of patients requested to not use the telehealth technology and instead use the telephone, which tells us something about perhaps the acceptability of certain types of technology. And again, in this study, the authors reported that there were barriers to participation for patients in terms of perhaps lacking the resources needed to access the telehealth technology, the use of a smartphone or computer, and having difficulty with the process in joining the virtual waiting room. So while these studies didn't directly capture patients' perspectives, they do allude to what may be some issues for patients and carers when trying to join technology-delivered sessions involving students and supporting students in their learning. So to conclude, actually what we're seeing most of the time in medical education literature reporting these technology-delivered sessions is a lower levels of involvement where actually students don't have any interaction with patients or carers. Patient and public involvement in teaching in this way demonstrates benefits to students. They're learning more about communication skills, and perhaps this is quite reflective of current healthcare delivery, which is providing students with relevant experience beyond the COVID-19 pandemic anyway, when we're looking at things like telehealth and remote consulting and the increased use of those that's likely to continue. However, no studies really captured the outcomes for patients or carers, so we still don't know whether they find the way that these teaching sessions are delivered to be acceptable, what the barriers might be, and whether actually anything supports them to join, to connect with technology-delivered sessions. We also found that language was really important, and actually some studies really varied in their use of the description of patients, involved patients and carers, commonly using terms like simulated and virtual patients without really describing what that means. So in terms of replication, there's a real barrier in some medical education research when describing where patients and the public have been involved. And we need to think about ways to move the literature forward so that we can really review the impact of patient and public involvement. Also, in terms of the language, the focus tends to be on learners and the benefit to learners. And perhaps we should be thinking more about the outcomes for patients and carers, and what it really means for them to be involved, and how they really want to be involved in medical students teaching. So the review has some implications for healthcare education broadly in terms of our understanding of the uses of technology to involve patients and carers in medical teaching. And we also need to think about how we can enhance placements for medical students so that they are gaining this real life experience and getting used to these interactions with real patients, and also to ensure that students are understanding diverse experience of patients with lived experience. We still don't know what populations have been involved. Are the patient groups being involved in medical students learning representative of local patient groups who students are likely to work with when they're qualified healthcare professionals? And we still don't really know what the barriers are for people who want to be involved. And how do we support these higher levels of involvement where we're asking patients and carers to work as partners in medical student curricula and assessment? So we did ask one of our public contributors for her reflections of being involved in the systematic review. And these are things that we discussed in meetings as we went, and our public contributors were fantastic in terms of sharing their views and telling us what they need to be involved in the systematic review. And she told me that the topic appealed to her because she had experience of being involved in medical teaching, but also that she feels that she's digitally excluded and has restricted access to the internet. So is interested in how teaching teams are overcoming those barriers for people, so that anyone who wants to be involved can be. We reflected on the fact that our public contributors were involved after the research question had been refined. So actually they missed that opportunity to sort of be involved in prioritising the research question and refining it. And in reflecting on that, we're thinking about ways to make sure that patients and carers are involved in designing research question and how we can go about funding that early level of involvement. There was some frustration there about not being able to access all the articles and the resources needed. So something we need to think about as researchers when we're involving patients and carers in our research teams is what resources they might need, and particularly with systematic reviews and evidence syntheses, how we're going to get papers across to people so that they can screen them. She really enjoyed the process she enjoyed being involved in systematic reviews and sort of understanding more about the processes involved in the systematic review, from full text screening to data extraction and analysis. And she found it really beneficial being involved in those meetings and felt that we had a good skill mix in the team of experienced researchers and early career researchers, students, and public contributors. So our public contributors felt comfortable asking questions because not everyone was really experienced in systematic reviews. So she really valued gaining that hands-on experience and better understanding the process. And she felt like it was a safe atmosphere to ask questions. And we were in touch over email between meetings as well, which helped in terms of being able to answer questions so that she could fulfill her role of reviewing the literature. So just the key points, taking away those reflections. Patient and public involvement at the point of developing the research question is important, and we need to think about how we make sure that we do that and have the funding to do that. We need to also remember that patients and carers have a new language to learn if they haven't been involved in lots of systematic reviews before, and making sure that meetings where we're reviewing our progress, we're making sure that there's time to explain certain concepts, and there's time for training in the use of, for example, quality assessment tools, so that they can be involved in every step of the process. We need to think about how to make sure public contributors have access to all the resources they need, either through the library or if it's particular software, and how we're doing that and how we're funding that. And we need to think about whether one size fits all in terms of standardising payments. We use the NIHR Involve payment schedule, which was really helpful, and particularly thinking about the sort of additional costs of being involved remotely. So there is some stuff there on the NIHR website. But does one size fit all, and how do people want to be paid, and do people want to be paid? And we need to be having those conversations at the point of seeking funding. So to conclude, we found 20 articles from our systematic review of technology-supported undergraduate medical education involving patients of the public. But most of the time there's a lack of interaction between students and patients and carers when technology is used. And there was a limited number of studies that actually looked at the involvement of patients and the public in students learning in real time. And these remote consulting studies have begun to tell us a little bit about what some of the barriers might be for patients being involved in perhaps this more modern software like video conferencing or telehealth software, telehealth platforms that can be useful for thinking about when we're involving patients and carers during COVID-19, and we're using all sorts of different types of technology. Involving patients and carers in the review process really enriches the perspective and can really enrich in systematic reviews and evidence synthesis. But we need to make sure as researchers that we're checking what people's support and training needs are, and what access they may need, to make sure that we've got that really diverse skill mix within the team. Thanks for listening. I hope you enjoy the rest of the webinar.
Thank you, Sophie and Sadie, for a great presentation. Now I'm going to invite Sophie and Julia back online for some questions and discussion.
Great. Thanks, Thomas. Julia, did you want to add anything?
Well, as the lay contributor on this project, and I would say, a little bit late to the party, I found it one of the, in terms of evidence synthesis reviews, it was one of the best I have ever worked on, and I say that in support of Sophie and Sadie. It was very inclusive for patients and public, and the benefit of that, it's not just us enriching and thereby at some point you have to put in training and your costs come down, because we can be relatively cheap people who are doing data extraction and analysis. And I'm sure that's not the reason that Sophie and Sadie had us there, I know. But from our perspective, well, from my perspective, what is interesting about it is that I get to see a wide range of papers of who's learning what and how it works. And that then gives me questions to ask for future projects or on future papers, which are perhaps even more pertinent, which is important, I think. So.
Thank you. And from the sort of the perspective of the research team, it was just wonderful having Julia and her colleague involved in the last review that Sadie was talking about. And Julia and I have also done some other work together on other evidence indices, but it really enriched the discussions around quite tricky. I mean, one of the questions that came up on the Q&A was exactly around that, and terminology, and how, you know, what's included, what's not, what counts as PPI in medical education, what doesn't. And these questions haven't been answered, and clearly you have to make a decision about what your boundaries are in any review. We wanted to be as inclusive as possible, but we also wanted to make sure that what we were counting as a case of PPI was something that we felt was valid, was legitimate. And so having those conversations with Julia and Nesrin and so on were really, really important. And what came up in those discussions was the importance of experiential knowledge and this idea of authentic PPI. So for that reason, we actually excluded some papers that were using actors and things like that to try and really focus this on what felt important to focus on.
A very simple example of support that Sophie and Sadie gave us was that I think it was Sadie, Sophie, if I may, produced an A4 with a flow diagram on it of how to go down from, you know, reading your abstract, reading your title to your abstract, and how to select your words to get down to, you know, taking the inclusion and exclusion criteria from it. And it made it so simple for us. It really was. It was foolproof.
She's amazing, Sadie. I wish she was here, but there she is, breastfeeding away. She's wonderful. Yes, so that's that. Go on,
some
Tom.
questions here, if you would like. I can. The first one was, I see you've answered already, but I think there's probably room for a bit of discussion as well. Did you say for PatMed that you conducted patient interviews and student focus groups? What informed this choice of interaction?
So we had a lot of discussions about what was the best way to make accessible the existing findings of the original review, how we could actually share the models and use them as a basis for discussion, and whether to start with the participants' own reflections and experience, or whether to begin with the models and all of this. And one of the key discussions was the process of engaging with the participants. And in the end, after discussion with patients and students, we decided to try and reflect an interaction that they were familiar with, which is why we went for interviews with patients, with that familiarity with a sort of healthcare clinician type one-to-one interaction. And with the students, we felt they were much more familiar with small group teaching. So we actually went for the focus group interactions with them, and it seemed to work relatively well. I mean, we didn't do a different method to compare it with, but the participants did report that they felt, you know, relaxed, and certainly the discussions and the data we got were great.
Thank you. We have another question here, and the person is wondering if there are any differences in concept between PPI involvement in medical education and expert patient tutor, where expert patient tutor is patients trained to educate students about key elements of history and examination signs specific to their disease, while providing constructive feedback about students' approach facilitated by clinician educators. So I suppose
So Julia, this reminds me of one of our data clinic discussions. Does it count? Does it not? I mean, I don't know what you think. I put something in the response that I wrote, but do you feel that?
Sorry, Sophie, I'm getting to grips with this. I'm typing an answer to another question. May I hang on to answer that, or I don't know how to jump out of the question I'm answering at the moment.
That's just fine.
Bear with me. Sorry.
I mean, I put my response. I think from what's described that does indeed relate to what we were talking about in the review. But it was, as I said, a really complex, difficult discussion at times about whether something was relevant to include or not. And I think in research, probably the term PPI has been defined slightly more tightly. I think in medical education, less so. And so, whereas in some of those early projects I was describing, we're talking about PPI involvement in the research process, or even changing the methodology to really embed PPI involvement. In that last project that Sadie was talking about, PPI were the focus. They were the actual sort of focus and content of the review that we were looking at. So I think what came out of that review was actually an important discussion to start about the terminology that we use and what we do mean in that broad range of ways. You know, no one wants to be constrictive about this, I don't think.
Please go ahead, Julia.
Thank you. In respect of that, I down at Oxford here do some co-delivery on both lectures and also interaction with small groups of first and third and fifth year students. And to me, what's in a name? You know, whether you call me an expert patient tutor, I'm not a teacher by background or profession. However, I know a lot about my own condition. I'm very knowledgeable, and provided somebody can guide and moderate, and there's always a professor or someone there to take that role. I'm not sure. I don't know. I think we have to be careful about professionalizing lay contributors too much sometimes. I think, you know, we lose our freshness then.
I think it is a spectrum. You know, right from service user, you know, the real focus of that interaction is for the person at that moment in time needing healthcare, and the student just happens to be there, versus someone who's actually agreed to come in and might have prepared some material as part of a seminar to be teaching in a slightly more distanced way about their experiences. But I think throughout all of those, what the process is trying to do is bring together that subjectiveness and the objectiveness. And sometimes the discussion might be more orientated towards the disease-based knowledge, sometimes more towards the experiential knowledge. But the whole beauty of having PPI within that is that you can actually integrate that and really make that real for the students.